All right, welcome to Pulmonary 8. First question, what enzyme is inhibited by PPIs? Well, PPIs are proton pump inhibitors like omeprazole, esomeprazole, lansoprazole, and pantoprazole, a whole bunch of these. But all these drugs inhibit the hydrogen-potassium ATPase, which is the countertransporter that puts hydrogen into the lumen of the stomach to make gastric acid and brings potassium into the parietal cell. And the last question, what are the C's of Huntington disease? So you have CAG repeats on chromosome 4 or chromosome 4. You can throw in quarenta to remember that this is typically seen around age 40. It can cause cognitive decline or dementia. And then there's chorea. Remember the old name for Huntington's disease was Huntington's chorea. And then finally you have atrophy of the caudate nucleus. All right, that's it for the quiz. I'll see you next time.
Hi again. I'm going to talk today about COPD and asthma. First off, when you're thinking of this, you need pulmonary function tests. The mainstay of pulmonology for these tests is spirometry. You have them take a deep breath in and then blow all their air out as much as possible. And when you do that, you get an FEV1, which is the amount of air they can blow out in 1 second, and a forced vital capacity, which is the amount of air they can blow out total. This ratio is normally about 80. In patients with a FEV1 to FVC ratio less than 80 is suggested of trouble getting air out or obstructive lung disease. When the ratio of FEV1 to FVC is greater than 80, it's suggested of restrictive lung disease, and they have trouble getting air in. This ratio is not perfect for diagnosing restrictive lung disease. You actually need lung volumes. But if you see a ratio that's very high, it's suggestive of restrictive lung disease. When I think of asthma, I think of famous people with asthma. The first one is John F. Kennedy, Pink, Jessica Alba, and then David Beckham. My wife made me put that one in for all the girls because JFK is so much older than everyone else. The asthma pathophysiology is classically you have increased sensitivity to certain things in the air leading to bronchial constriction that's typically reversible. The beta-2 receptor stimulation leads to bronchodilation. And the classically way this is done is albuterol. And this improves the bronchodilation and possible improvement in the FEV1-FVC ratio. Other pathophysiology features are smooth muscle hypertrophy, leading to hypertrophy of these muscles, and bronchospasm. This bronchospasm can go on to lead to air trapping. Some of the pathology you see in the pathology section of asthma you see are Kirschmann spirals. They're spiral-shaped mucus plug and desquaminated epithelium. They're seen in asthma and obstructive lung disease. And the clinical significance is not understood very well at this time. Another one is Charcot-Leyden crystals. They are associated with eosinophilic inflammation. Classic asthma triggers are certain medications, emotional stress, cold air. If you start exercising a lot, some people have exercise-induced asthma. And then you can imagine living in Los Angeles, all the air pollution people are exposed to. And then if you're in Texas, we're exposed to a lot of allergens with the changing seasons. The classic symptoms for asthma are cough. Sometimes this is the only feature they have, and it's known as cough variant asthma. Most patients will wheeze, have shortness of breath, tachypnea, hypoxia. They typically have a short inspiration and a prolonged expiratory time. When it gets really bad, they purse lip breathe. Sometimes it leads to pulsus paradoxus if it's very severe symptoms, and mucus plugging. So what is pulsus paradoxus? It's an abnormal drop of 10 millimeters of mercury of systolic blood pressure during inspiration. What happens is there's decreased interthoracic pressure leading to increased right ventricle blood return. This causes the right ventricle to compress the left ventricle, decreasing cardiac output to the rest of the body. It's seen in cardiac tamponade, asthmatic patients, and sometimes in patients with severe pulmonary embolisms. Diagnosis for asthma by pulmonary function test is they have a bronchodilator response of 200 cc's increase or 12% increase in the FEV1 or FVC ratio when they're given a bronchodilator. You can also use a methacholine challenge to see if they have a decrease in the pulmonary function test at FEV1 of 20%. Aspirin-induced asthma basically occurs because there's inhibited production of COX-2 by the aspirin. This leads to overproduction of the leukotrienes, and as a byproduct, the patients will have symptoms of asthma, nasal polyps, and aspirin hypersensitivity. When we think of COPD, I first want to think of famous people. Jimmy Fallon doesn't have COPD, but most of you don't know all the famous people before him that did the late night show before him. Jay Leno didn't have COPD, but the most famous person who was the king of late night before all these people and made late night famous was Johnny Carson. And he did the Tonight Show for over 25 years and had countless actors and actresses come on board, and he was the center of the ring and the most famous person for doing this. Unfortunately, he smoked a lot and developed COPD and died prematurely. COPD is due to airway inflammation, and it leads either to chronic bronchitis or emphysema. Chronic bronchitis, the blue bloater, is consistent with chronic productive cough for greater than 3 months for more than 2 consecutive years. It's a clinical diagnosis, not a histological. It can occur before or after they develop airflow limitation, and typically is caused by long-term irritants and infection, and the most likely irritant is chronic smoking. The symptoms for people with chronic bronchitis are wheeze. Some will have crackles. Many of them will be cyanotic, especially if they're hypoxic. They have shortness of breath. They'll develop peripheral edema in the lower extremities. Some will develop pulmonary hypertension, hypoxia due to shunting. They'll have carbon dioxide retention, and they'll develop secondary polycythemia. In patients with chronic bronchitis, they have hyperplasia of both the goblet cells and submucosal glands. When you see this hypertrophy, you can actually measure it using something called the Reed index. The Reed index is when you measure the thickness of the glands between B and C, and that's the size of the goblet cells or the submucosal glands, and then you divide that by the thickness of the walls between A and D, the distance between the epithelium and the cartilage. And if this is greater than 50%, is representative of an elevated Reed index. When you think of emphysema in a normal person, they will have a normal anterior to posterior diameter. In patients with emphysema, they have air trapping, and this anterior posterior diameter gets increased, and it leads to barrel chesting, which you can see in the picture. Emphysema will have flattening of the diaphragm, and again, you can see on the lateral view of this chest x-ray, increased AP diameter and prominent central pulmonary arteries. The acidness of patients with emphysema are the most abnormal things. The normal acidness represents the terminal bronchia, which consists of going from proximal to distal, the respiratory bronchioles, the alveolar duct, the alveolar sacs, and then the alveoli. Central acinar emphysema has damage to the respiratory bronchioles, and the rest are spared. And this is represented in someone who smokes. Pan-acinus emphysema is represented by someone with alpha anti-1 trypsin, and this is damage to the whole acinus. In patients with central acinar emphysema, it's normally from cigarette smoking, as I mentioned, and it involves the upper lobes, where pan-acinus involves the lower lobes and is consistent with alpha-1, as I just mentioned. Patients with emphysema, you also have a classic feature of a pink puffer. They have pursed lip breathing to prevent the airway collapse. They typically do not have cyanosis and actually are very red normally. They have severe shortness of breath and a risk for spontaneous pneumothoraces from a rupture of a blood. Pink puffers with emphysema typically have low DLCO. They have increased compliance because of the loss of elastic fibers in their lungs. Alpha-1 antitrypsin is classic for emphysema of the lungs, and sometimes you'll even see cirrhosis of the liver. These patients typically have early onset emphysema in the 20s and 30s, especially if they smoke. Typically, emphysema is delayed into patients' 50s or 60s, and it's mainly due to the inability of the alpha-1 to be present to prevent the breakdown of elastase in the lungs. Alpha-1 typically protects against this, and these elastase damage the lung when they're unopposed. The classic features of alpha-1 antitrypsin, you have emphysema in the lower lobes, which you can see here with pan-acinar emphysema. Bronchiectasis is another feature, lung disease. Bronchiectasis is most easily defined on a CT scan. You can see in the middle of the screen, you can see the division of the right and left mainstem bronchi in the center of the screen. As you go out from the center of the screen on the right mainstem bronchi, you can see the airway stays the same size and doesn't decrease in size. In a normal person, the airway should slowly get smaller and smaller, but in this patient with some type of bronchiectasis, the airway stays the same size. This classic symptoms for bronchiectasis can be found based on a TV show called The X Factor. You all remember Simon Cowell when he was on American Idol or his news show, America's Got Talent. He had a lady try out on this show between those two shows called The X Factor. And she tried out, and unfortunately she didn't do very well. After she tried out, only he would say, "You have a very weird sounding voice. Are you aware of that? It's like someone else is in there." And then his co-judge, Sharon Osbourne, piled on, "You need to see a doctor." So the lady actually listened to Dr. Cowell and Dr. Osbourne's advice. And she went to a doctor and actually had bronchiectasis. It's kind of amazing that they're so in tune to the way people's voices should sound that they were able to recognize severely abnormal voice. The classic features for people with bronchiectasis is more common in women. They have productive cough, increased sputum production. Many of them will have sinus disease. It's rare for them to have hemoptysis, and they have daily sputum production. The shortness of breath is largely based on the degree of pulmonary function test decline. The pulmonary function tests tend to be obstructive, and the most common causes for bronchiectasis are allergic bronchopulmonary aspergillus, a fungus creating an inflammatory response. You will see central bronchiectasis, and the classic buzzword for this is central bronchiectasis or finger and glove, where you see a thick airway with mucus impacted in it. Cartager syndrome, where you have reversal of the organs, where the heart will be on the right side instead of the left. Most common cause of bronchiectasis is cystic fibrosis, and then another one that you will often see is primary ciliary dyskinesia. Now that we've finished the lecture, it's time for a quiz. So do the quizzes and then return to the video when you're ready. All right, are you ready now? What are the hallmark characteristics of obstructive lung disease on pulmonary function test? The hallmarks on this are, it's difficulty getting air out, they have increased total lung volumes, and their FEV1 to FEC ratio is typically less than 80. What are the hallmark characteristics of restrictive lung disease on pulmonary function tests? They have decreased lung volumes, and their FEV1 to FEVC ratio typically are increased. They have a high ratio, and they generally cannot get air in. What is the Reed index? If 50% of the bronchial wall is composed of mucus-secreting glands, there's an elevated Reed index. The ratio between the thickness of the submucosal glands and the distance between the epithelium and cartilage. How does emphysema caused by smoking differ from emphysema caused by alpha-1 antitrypsin deficiency? Smoking is typically central acinar, and alpha-1 is typically pan-acinar. That's the end of session quiz. Now let's do some rapid fire facts. A blue bloater is someone that's hypoxic, hypercapnic, and has chronic bronchitis. A pink puffer is someone that has dyspnea, hyperventilation, and emphysema. And finally, a Kirschmann spiral sheds epithelia from mucus plugs. It's found in someone with asthma. That's the end of video for COPD and asthma. See you next time.